Hi everyone, this is Professor Tagwire again, and this time we want to be talking about mushroom poisoning. And before I start, on the lecture materials, I would like to start by just reading through um, this extract of an article which was published in the Chronicle from Bulawayo a few years ago. This was in 2018. And the story reads something like this. It says 7 more people from the same family have died at Mpilo Central Hospital in Bulawayo after consuming poisonous mushrooms in Berengwa, bringing the death toll to 10. The extended family from Mukuta village in Berengwa consumed the deadly mushrooms at home, and 3 died last Thursday, while 11 were admitted to Mpilo Central Hospital. 7 of those who were admitted died over the weekend. Mpilo Central Hospital Clinical Director Dr. Solwayo Ngwenya said 6 children and 1 male adult died while admitted at the hospital. And then court, we received 11 people last week who had allegedly consumed poisonous mushrooms. We lost 7 of them, 6 children and 1 male adult over the weekend, he said. I want to warn members of the public to desist from consuming mushrooms they randomly pick from the bush to avoid endangering their lives. People must avoid buying people must avoid buying even those mushrooms that are being sold by vendors on the streets in the city center of Bulawayo. Dr. Ngwenya could not immediately release the names of the 7 deceased persons. However, on Sunday, police identified 3 children who died last week as Modesta Shoko, Prince Tole, Presence Ngwenya, aged 7, 7, and 8, respectively. Police said those children were part of the extended family that allegedly consumed the poisonous mushrooms last Tuesday in Mukuta village. The family members who were left ill were taken to Masase Mission Hospital before they were ferried to Mpilo Central Hospital after their condition deteriorated. Acting Midlands police spokesperson, Assistant Mukwende, said at about 4 p.m. last Tuesday, Mr. Tenias Shoko, aged 45, sent his 16-year-old daughter to pick some mushrooms for relish. She said the 16-year-old prepared the mushrooms, which were consumed by the whole family. The following morning, some children consumed the same mushrooms which were left the previous night, preparing to go to school before they started complaining of stomach pains. Suddenly, Modesta became serious and died around 12 midday, she said. The inspector said Prince and Presence died on arrival at Msase Mission Hospital. And that's the end of the article. So I just want to talk about mushroom poisoning, and the slides which I have in this particular talk were prepared by my colleague Louis Gadaga, who is also a poisons information pharmacist, pharmacologist, and toxicologist. Actually, I see his qualifications are not updated there, and myself. So I think that what we've just read there is a classical story of what mushroom poisoning in Zimbabwe looks like. That when mushroom poisoning occurs ordinarily, at least for the lethal mushrooms, it normally takes the lives of a significant number of people. Ordinarily, whole families are actually wiped out. This was the case which occurred in Bulawayo, but in my years practicing as a clinical toxicologist and a poison information pharmacist, I mean, I've come across a number of cases, one in Epworth where 7 people died. It's always a large number of people who die. And like we said earlier, if you go through the talk on plant poisoning, the issue of hunger becomes an important one when it comes to plant poisoning. And in fact, you find that for most cases of plant poisoning and mushroom poisoning, the cases normally spike in times of famine or in times of drought, where people look for alternative sources of relish and go out beyond what they are used to taking. Others hunt for mushrooms, others hunt for other leaves and plants that they ordinarily would not take. And this is something that we did experience in Zimbabwe, during the time 2006, 2007, 2008, thereabouts, when, the economy just plunged and people started, looking for alternative sources of food. So in this particular lecture, I just want to spend some time talking about mushroom poisoning and hopefully mention some important things that will be of assistance to students when they go out practicing as pharmacists or as clinical pharmacologists or as nurses or as other healthcare professionals, doctors, you name it, whosoever might benefit from today's lecture. So as an introduction, mushrooms are the sexual organs or the fruiting bodies of fungi. So they're not really plants. They are not plants at all. Actually, they are fungi. And mushroom poisoning can occur after the consumption of either the raw mushrooms or even cooked mushrooms. As you shall see, the mushrooms that we worry about, the Amanita phalloides, the one that's likely to have been the culprit in the cases that we have just read. The toxic components are actually not destroyed by cooking or heating, which makes it a very deadly compound, a very deadly source of toxic substances. So in Zimbabwe, mushroom poisoning commonly occurs during the wet seasons, the rainy seasons. That's when mushrooms sprout up. And also, like I said earlier, mushroom poisoning cases also increase during times of, either hunger or economic difficulties, as people look for alternative sources of relish because perhaps their pockets are not as deep as they are supposed to be. And most mushroom poisoning in Zimbabwe are due to cyclopeptide containing mushrooms which belong to the Amanita species. And I should just hasten to say that not all mushrooms that belong to the Amanita species are actually toxic. There are some which are actually edible and can be eaten. So the Amanita species are reputed to be responsible for 90% of mushroom poisonings worldwide. And in most cases, fatalities are as a result of the species which is known as Amanita phalloides, which I suspect was the culprit in the case that we read at the beginning of this lecture. So identification of mushrooms is quite difficult, and complete and precise identification should be accomplished by an experienced mycologist. And there are actually documented cases of experienced mycologists being poisoned, picking mushrooms which are actually poisoned and eating them inadvertently. So, mushroom picking shouldn't be something which is just taken willy-nilly, but there should be people who are experienced. In this particular case that we read about, we had a 16-year-old. I'm not sure what her experience was in picking up mushrooms, but she's the one who is said to have been sent to go and pick up the mushrooms, and it is possible that in picking those mushrooms up, she then picked up some of the toxic ones, which then resulted in the whole family being poisoned. So there are about 4 basic features to look out for with regards to mushrooms that belong to the Amanita species, where we've got the toxic Amanita phalloides. And these 4 basic features of the Amanita species are shown in this sketch. So all of them have got white gills, and then they have a membranous skirt, and then right at the bottom there's what is referred to as a cup-like structure, which is often referred to as I like to put it, the cup of death. And then one other feature which is lacking here, ordinarily on top of the caps or on top of the umbrella body here, you have wart-like structures which are actually associated with the Amanita species. Well, the 4 things, so the white gills, membranous skirt, cup-like structure at the bottom, and then some wart-like features at the top of the of at the top of the cap. But then one thing that you should note, if you know mushrooms, they are quite fragile, so it is actually possible, which makes it really complicated in terms of the identification, because some of these like the membranous sket will be quite delicate and can easily break off. The cup of death can also easily break off, such that you might find a mushroom which has got the cup of death broken off, and you might think it's not the Amanita species, yet it actually is. So Amanita phalloides, which is the one that we worry most about, has a pale greenish to yellow or white cap with white gills. The skate-like structure is closely located close to the cap on a white bulbous stem, like I showed you, and is surrounded by a large white vulva at the bottom, which are referred to as the cup of death. We have two other species which are reportedly found in Zimbabwe, which is Amanita muscaria, which has got a very distinct red color. I shall show you some pictures of these particular mushrooms with some whitish soft warts on top of the cap. And then we have Amanita pantherina, which always has some shade of brown or brownish gray in terms of its color. The cup of death, the skate-like structure. Can't really see the white gills here, but I think on this one we can see the white gills. And if you look at Amanita pantherina, still got the skate-like structure at the bottom, something that resembles the cup of death, not really the cup of death, and then some wart-like structures at the top. But you would want to eat something which looks like this with the wart-like structures or something. And the same with Amanita muscaria, the skate-like structure. Okay, we can't really see the cup of death, but basically those are the Amanitas. So with regards to the toxicology or the toxins, Amanita phalloides, which is the one that we worry the most about, contains three classes of toxic substances: the amatoxins, virotoxins, and phallotoxins. Virotoxins and phallotoxins are present in smaller concentrations and are heat liable, which means these ones basically, if you cook the Amanita, they break down. So they are generally of less concern from a toxicological perspective. What we worry most about with these Amanitas is what's referred to as the amatoxins, which are of most concern from a toxicological perspective, with alpha amanitin and amatoxin being the most toxic substance. And unlike, the virotoxins and the phallotoxins, the amatoxins are not heat liable and therefore will actually not be destroyed by heat. They're insoluble in water and are not destroyed by drying. One would refer to this probably as the ultimate poison or the ultimate poisonous substances. And these are the ones that basically, toxins lead to the toxicology that we saw, where those children and those family members were actually killed. Amanita muscaria and Amanita pantherina do not contain any amatoxins. Instead, they contain psychoactive isoxazole derivatives. Isoxazole derivatives and butanic acid, as well as mucimol. And basically, these act in the central nervous system. And you'd get euphoria, perhaps you might get some dizziness and other things like that. You also have muscarine in small traces in either pantherina or muscaria, and some of the compounds contained in these mushrooms have got atropine-like effects. So these are basically towards the central nervous system toxicologically. In terms of the toxicokinetics, phytotoxins, which are extremely potent, hepatotoxic substances, but are not well absorbed from the GIT tract. They are heat liable and therefore play no role in human poisoning, and this is something that we talked about. On the other hand, amatoxins are not hydrolyzed by enzymes in the gastrointestinal tract of mammals, and are actively absorbed from the small intestine. So that's a very efficient poison, so to speak. They concentrate in the liver and the kidney cells, leading to necrosis of the hepatocytes, as well as the proximal tubules of the kidney. So basically, you're destroying the liver, you're destroying the kidney as well, and cause fragmentation of the nucleoli as early as 30 minutes after administration. So changes in the cytoplasm occur as early as 48 hours after poisoning, rapidly leading to necrosis. So you get necrosis. And then the parenchymal cells of the liver and the kidney are targeted by these low molecular weight amatoxins. And in terms of the mechanism of action, they interfere with both DNA and RNA transcription by primarily inhibiting RNA polymerase 2. And because of that, the mechanism of action is really it's destroying, rapidly dividing cells. So cells with the highest rate of multiplications are such as the gastromucosal cells, the liver and the kidney cells are injured first. And that's the reason why you'd find in the symptomatology you get diarrhea, you can get vomiting or carrying abdominal pains because of those cells in the mucosa. The lethal dose of amatoxin is estimated to be approximately 0.1 milligrams per kg, which is quite low. And concentrations of 0.2 to 0.02 to 0.03 milligrams per kg have been found in some of the mushrooms. So in terms of the clinical features of poisoning and differential diagnosis, poisoning from Amanita phalloides can be differentiated from that of Amanita muscaria by the onset of symptoms and the clinical presentation. Symptoms of Amanita phalloides poisoning are delayed, whereas those of the other Amanitas have got quite a rapid onset. So if someone has taken mushrooms and between 30 minutes to 1 hour, you start seeing signs and symptoms largely directed towards the central nervous system, then you'd not be that worried, because then it might be Amanita pantherina or Amanita muscaria, which has got psychoactive substances. And then for Amanita pantherina and muscaria, you usually get dizziness, euphoria, maybe some muscle spasms, maybe visual disturbances. So for mushrooms with high muscarine content, the symptoms might resemble those of cholinergic overdrive, probably what you'd see more or less with organophosphate poisoning, but maybe not to that much of an extent. Amanita phalloides, on the other hand, the poisoning is split into 3 or 4 distinct phases. It depends how we want to name them. The first phase is a latent period whereby apparently there are no effects, but in the meantime, what is happening at the background is that there's necrosis occurring in the kidneys, there's necrosis which is occurring in the liver, but the patient actually seems pretty well, which makes it again an efficient poison, because by the time you start seeing symptoms, by the time you start getting abdominal cramps, by the time you start getting diarrhea, already significant damage has occurred to the major organs which are targeted by it. Then there's a gastrointestinal phase, which we'll talk a bit more about. Basically where you've got rice water-like diarrhea, like you'd get in cholera. You have abdominal cramps, you have pain. And then afterwards, there's clinically apparent hepatic phase, as well as renal failure, and the fourth phase would be death, which can occur. So a bit of more detail with regards to the phase. The phase 1 is a latent period, where Amanita poisoning is a characteristic latent period which can last between 6 to 12 hours post-ingestion before the onset of any clinical symptoms. So despite the lack of symptoms, like I said earlier, the Amanita is binding to the RNA, and we said RNA polymerase, causing damage to the various target organs or cells. The second phase is the gastrointestinal phase, which after the asymptomatic period, you get abdominal cramping, you get vomiting, you get profuse watery diarrhea, rice water like you'd get in cholera, and then you get heavy fluid losses because you're vomiting, because you're having diarrhea, and this could actually lead to circulatory collapse at this phase, at phase 2. Phase 3, which can occur maybe after a day or so, even less. The patient might seem to be improving, yet there's ongoing damage, as indicated by elevated liver function tests and prothrombin time, because the liver is now not functioning well, so clotting factors not being produced, so prothrombin time would actually increase. So this stage might actually last between 2 to 3 days. And hepatic and renal injury become clinically apparent and may progress to fulminant hepatic failure, which actually may require that there be a liver transplant. And stage 4, or death does occur ordinarily between 3 to 7 days, but can actually be even less, as we saw in some of the cases that were reported in that newspaper article that I read to you. So in terms of the general clinical features, just think of what would happen if the liver has been damaged, what would happen if the kidney has been damaged. So the symptoms are largely attributable to hepatic dysfunction such as jaundice, lethargy, bruising. You can have tachycardia. Tachycardia largely because we talked about the profuse diarrhea. There might be loss of fluids. So therefore, you can have tachycardia. You can have hypotension. You can have poor turgor or turgor because of that dehydration which occurs. And neurological symptoms can occur as a result of either hypoglycemia or the hepatic effects, or even the dehydration itself, leading to confusion, lethargy, and coma. And also, you don't forget the damage to the kidneys, which can also come with its own attendant signs and symptoms. In terms of management, well, if you do realize that people have taken the poisonous mushrooms, because this is food and they actually chewed, one of the best approaches to take might be to do gastric lavage in as short time as possible. But like we saw in this case, ordinarily, by the time patients realize that they've been poisoned, it's almost too late, because the symptoms occur way after the latent period, and by the time a patient comes, it's almost already too late. But if you do realize that you've taken poisonous mushrooms, then you can use gastric lavage, an oral gastric tube or a nasogastric tube, but with a large bore, so that the little particles do not clog the bore. And then administration of activated charcoal can actually interrupt enterohepatic circulation and could actually be of assistance in cases of poisoning. Diuresis has been suggested as a means of eliminating the amatoxins. Dialysis methods apparently are not useful, except perhaps in cases of renal failure. And then aggressive IV rehydration, glucose replenishment should also be carried out. We talked already about the dehydration, and then we also talked about the fact that the liver is affected, so you got your glucogenesis, which is also affected. Therefore, glucose can actually be quite useful. And then in terms of management, the number of drugs have been used, because to date there isn't really any antidote which has been found to work in cases of Amanita poisoning, but a number of drugs have been experimented with. And the following drugs are thought to actually reduce uptake of amatoxins into the hepatocytes, or, as in the case of celibinin, might actually be able to assist in terms of, put loosely, in terms of maybe regenerating the liver cells, or even perhaps protecting them. So you have high-dose benzalpenicillin, which is thought to actually reduce the uptake of the amatoxins, perhaps. Celibinin seems to have some hepatoprotective effects. And then vitamin K for coagulation problems, because remember, clotting factors are not being produced as much as they should. Then in terms of the laboratory tests that you would do, use and ease, very important. Your liver function tests, your coagulation parameters, serum glucose, as well as other tests which the clinician who is attending the patient may find to be of importance. In a nutshell, that is poisoning from mushrooms. And like I said, the most important one in this particular case is Amanita phalloides, which is the one that we tend to be more concerned about. Amanita pantherina, Amanita muscaria, you can get cases of poisoning from those. But in my years, I've hardly come across any cases, at least which have required admission from Amanita pantherina or Amanita muscaria. So I hope students manage to get something from this and to learn something from this. And one thing that I would suggest is that all the cases, or all the lectures on clinical toxicology, just make sure that you read or you go through all of them, because there are some things which I talk about here which I might not necessarily have talked about in terms of plant poisoning, but are also equally important. So having said that, I wish you all students the best. I think this was the last slide that the last lecture that I was doing on clinical toxicology. I hope you found all these lectures quite useful. And yeah, all the best with your examinations and all the best with your clinical practice after you finish your degrees. Otherwise, thank you very much. Until we meet next time, this is Professor Tagray, aka Prof. Toxin, saying goodbye, and I'm out. Until we meet next time, goodbye.